So we'll start first with just getting, everyone involved a little bit here, and then we'll get into the nitty gritty. So in terms of craniofacial disorders, everything really comes down to understanding how to interpret what you're seeing in terms of a child's calvarial or skull and facial morphology, the way they look. And so really the majority, as you'll see as I go through how to diagnose these disorders, the majority of this skill is all in physical diagnosis. It's in physical exam, which is what makes it really interesting and engaging. So yes, we can use scans, typically CTs, not really X-rays or MRIs, because we're looking at bone anatomy and whether or not the bone structure is normal or abnormal. So typically we're using CT, and that's not really something you want to use a lot in the infant population because of the exposure to ionizing radiation. And so really it's a nice art because there's huge reliance on physical exam still. So important to understand the terms we're using, what they mean in terms of how we're describing a patient's head shape, and then how that starts to key us in on what might be going on. So I'm trying to think of how to do this best since I can't see you guys and you can't talk to me. Can I see your chat questions? So I'm trying to look at the bottom to see if I can.
We should be able to, yeah.
I know, and I can't see the bottom. Let's see. Because I'd like you guys to be able to answer these for me. Or if you can see them, then you can let me know what people are saying.
Yeah, I can do that.
So, all right. What is this entity of the selections on the left? Which one of these is this? Do we have any answers or any takers? Radio silence.
Yeah, not yet.
Okay, no, it's good. It's good. It gives me a sense as to how much we need to go over. And
someone says brachycephaly.
Excellent, brachycephaly. So this is symmetric flattening of the back of the head, or brachycephaly. So as we go through how to diagnose different synostoses, this will key us in on either a form of benign plagiocephaly or coronal synostosis, and we'll go over that. All right. What is this one? Somebody knows. If you know brachycephaly, you know this. Nothing. This is scaphocephaly, okay? And so we'll go over the details, but scaphocephaly, elongated boat-shaped head. That's why it's called scaphos. All right. Anyone? What is this?
Oh, trigonocephaly, someone said?
Yes, trigonocephaly. Excellent. Ooh, and now I can see you, John, Raquel. Okay, good. All right. So yes, trigonocephaly, indicative of metopic synostosis, which we'll go over. Okay. What's this one? Nothing. Yes, excellent. That's a tough one. And we'll go over why. That was plagiocephaly, and then I clicked one too quickly because I was trying to get the chat back up. And then lastly, what's this one? Ignore that. Sorry, when I clicked to try, there we go. Nothing? Something? Nothing. This one's tricky. So this is anterior plagiocephaly or coronal synostosis. All right, so we'll go over that. And then lastly, this is toricephaly, toribrachiocephaly, syndromic synostosis. All right, so how do we figure all this out? So first, let's start with the simple stuff to get it out of the way and understand benign versus surgically pathologic. So a 2-month-old baby presents to your clinic for a routine well baby visit. They were born via term vaginal delivery, no complications. The child is gaining weight well. Parents are concerned about the head shape. They describe that this child has a difficulty turning their head to the left since birth, which you would note as torticollis, and you notice an associated right-sided occipital flattening with anterior displacement of the affected ear and forehead bossing. This is what this child looks like. So displacement along the right side, flattening on the right, ear pushed forward, forehead pushed forward. So This is what this would look like if we represented this schematically. Again, flatness along the back of the head, the anterior displacement of the ear called dystocia, and anterior displacement of the forehead. So this is plagiocephaly. So this is the only benign entity. Everything else we're going to talk about today is surgical. This is plagiocephaly, okay? So the cranial asymmetry is secondary only to forces that deform the skull from external to internal. So different from synostosis, which we'll go over, which is clearly an internal to external result of pathologic skull shape. This is simply from children having a preference, being put to sleep on their backs, or having true torticollis, meaning they physically can't turn their head well in one direction. There are a lot of other factors, meaning you always want to ask a mother if they are breastfeeding, and if they are breastfeeding on one side or the other exclusively, because your forearm is hard. And so if you have differences in production, you have to learn how to ask these questions. They'll say, oh yeah, I have differential production. I'm only ever feeding my kiddo on the right. Well, the left side of the head's going to get really flat because it's resting on the mom's forearm all day. Or are they being bottle fed exclusively? That's another issue. If somebody's a righty or a lefty and they're only getting bottles, they're not shifting back and forth. So, there are all these little tricks that you start to learn, but the bottom line is this is not surgical. This is benign. This gets better on its own. It started to really crop up since the Safe to Sleep campaign, meaning every child is put to sleep on their back since 1994 to decrease the incidence of SIDS. You see the characteristic morphology that we just went over, meaning there's asymmetric flattening of the occiput. There's a characteristic lack of ridging. There's a lack of compensation, which we'll go over what that means, and longitudinal improvement, meaning usually this starts to get better over time. You ask the parents if it's getting better or worse, and they say, no, we noticed some flattening. It's getting better. The treatment for this is just behavior modification. You get these kids on their bellies, aggressive tummy time, physical therapy for the torticollis, plus or minus helmet therapy. I'm very against helmeting. I think it is, it just doesn't have a role. We've found over the last 10 years that children get better on their own exactly the same as what helmet therapy would accomplish. So I tend to stay away from it. You do not need imaging. This is physical exam only. And children get better with time, physical therapy, and behavior modifications. By age 2, you usually see this decrease substantially to a point prevalence of only about 3 years. And when you look at teenagers, only about 2% of the population feels that they have any residual flattening. All right, so that gets the benign out of the way. Again, helmet therapy not needed. So let's move into the surgical entities and those that we treat as a surgical team. So let's review the sutural anatomy first, because this is what we'll be dealing with for the rest of the talk. So the infant's skull is simply a composite of big tectonic plates. They're not fused because you need to allow for delivery, in which through typically, if it's going to be a vaginal delivery, the overriding of those bone plates so that the calvarium can get through the birth canal. And then once delivered, you need to allow for brain growth. So the skull cannot be static during early infancy and into 2 to 4 years of age, so that you can allow for brain growth and all of these rapid changes that are occurring. So nature's solution for that was sutures, which are natural openings in these bones that allow for growth, and they also allow for overriding. So we see those represented here. They are sites of dynamic bone deposition and resorption. Alternatively, as the skull grows, they allow for adjustments in size and shape over time, and they are viewed as these little spiculated bony projections with these irregular edges over the pericranium. What happens is there is stretching of those sutural ligaments between the sutures as the child's head grows, and that stretching indicates through chemical gradients and chemical mediators to keep those sutures open. It states, nope, the brain is growing. We need these open. Keep these open. Do not lay down bone yet until they start to lessen those signals, lessen and lessen and lessen as the child's head stops growing as actively, and therefore then the signals shift to, okay, we can now shift from bone resorption to bone deposition along those ridges, along those sutures, and then you end up with a fused skull somewhere around the age of 4 to 5. So looking at how quickly these close, so in terms of the anatomy, number 2 here, that forehead suture is the metopic suture. Can you see my arrow? Okay. Looking at number 4 here in the sagittal view, that's the coronal suture, and you have paired coronal sutures on either side. Moving back here to the lambdoid suture, number 18, and looking from a bird's eye view, number 29 is the sagittal suture. Those are the most commonly important. There are a lot of other ones that you see here. For myself as a craniofacial surgeon, they're actually all important because of the midface fusions that develop in syndromic children. But for this purposes of this talk, we're going to stick to the larger, more significant ones. So these sutures close at different times throughout an infant's life. The metopic closes first, and it can close as early as 2 months. Typically, it will start closing at 4 months, then the sagittal suture, then the coronals, and then the lambdoids. The squamosal is this little one down here. It's not that important clinically. So it's important to know these numbers because children will come in as in referral all the time for assessment of ridges. And you have to be able to figure out the difference between a normal ridge just because of active bone deposition versus a pathologic ridge that represents synostosis or early fusion. So the metopic, being the earliest to close, always will start robustly ridging about 4 months of age. It causes common concern. I assess hundreds of these kids every month for ridging that is not fusion. And we'll talk about how we know why. So what is craniosynostosis? So it's the ossification of one of these calvarial sutures before the functional need for adaptation of the skull is complete. So an infant could have closure of all of their sutures at 4 or 5 months of age if they don't need head growth. You know, why would that happen? There are children that have ischemic insults during delivery, hypoxic ischemic encephalopathy, perinatal strokes, migrational disorders. These children, and those are all separate talks in of themselves, but those children are not going to have normal brain growth. And so they're not going to receive the signals stretching the fibrous ligaments between the bone plates, telling those sutures to stay open, and they'll close them. But that's perfectly appropriate because that child actually doesn't need room. It doesn't need a larger skull because their brain is not going to grow to a normal capacity. So again, that child wouldn't have a functional need. So if they close at 4 months of age, that's actually normal for that child. So you have to understand and be very aware of the overarching global picture of these children in order to diagnose them appropriately and to avoid intervening inappropriately, right? So I see this often, second, third referrals, second, third opinions, etc., for a prematurely closed suture. You have to understand the context of that for the child to know, does this represent pathology? Does this child actually need treatment? The last thing you want to do, of course, is to intervene inappropriately. So the ossification zones are the sutural zones. They're composed of zones of alteration. And there are isolated forms of synostosis, meaning it's just one suture involved. And then there are syndromic forms, and those are genetically driven. They're all autosomal dominant for the most part, and we'll look at what those look at. The isolated forms are not genetically driven, meaning there are genes responsible for them, and we'll talk about them, and we're doing some really interesting research about that right now, but they're not heritable. So we don't see it passed down from family member to family member, but yes, there are genes that are responsible for synostosis. The syndromic forms are absolutely heritable, and they result in multi-suture involvement. Typical incidence is 1 in 2,500 births. All right, so what do these look like? What are the forms of compensation? So we'll go around this wheel quickly, and then we're going to take them each individually. All right, so normal is in the middle here, and we just went over the sutural anatomy, so we're all comfortable with that. So let's start here at 1 o'clock. This is sagittal synostosis or scaphocephaly. So you're missing the sagittal suture. They also didn't draw in the metopic. It's because it closes so early. It's often closed in these kids. So you're missing your sagittal suture here. That means that the skull cannot grow perpendicular to the fused suture. Does that make sense? Right? So usually, if you have an opening in the bones that allows for growth perpendicular to that linear opening. So if you're missing the ability to grow perpendicular to that opening, it will cause compensation along the axis of the suture. So because you're missing your sagittal suture, the brain can't grow and the skull can't grow in this direction, which we call the biparietal direction, which narrows the skull. It holds it in a narrow position. And then the brain is looking for room to grow. And so it uses the sutures it has. And so it's going to use the coronal sutures. And you'll get frontal bossing because the brain's going to push those forward. And you're going to use the lambdoid sutures. pushing the occiput backwards. And so that gives you that resultant elongated, boat-shaped, scaphocephalic skull. If you're missing your metopic suture, the frontal bones can't grow perpendicular to the metopic suture. So of course it's going to narrow the forehead because it's stuck centered around this bone. And it's going to use everything else it has for brain growth. So your coronal sutures are available. So the brain's going to push backwards more. You have your sagittal suture, so it's going to push out more. So you end up with a triangular shaped head because you're narrowed at the front where you're stuck. And the compensation is occipital bossing in trigonocephaly. So when we're talking about compensation in synostosis, we mean the resultant head shape because the brain is compensating for the area where it can't grow. All right, if you have both coronal sutures fused, you end up with brachycephaly, flatness along the back of the head and foreshortening of the skull because, again, can't grow perpendicular to these sutures. So your skull is stuck in a very narrow, in a different dimension, right? AP dimension, AP, so an AP limitation, and you get brachycephaly. Unicoronal is one of the most difficult to diagnose and distinguish from plagiocephaly. So here's plagiocephaly and here's coronal synostosis. So in this image, you're missing the left coronal suture. So the skull is stuck around this fulcrum, meaning can't grow perpendicularly. So your forehead is flat, and here's the difference. The back of the head is also flat on that side. Your ear is pulled forward towards the ridged missing suture, the missing fused, I shouldn't say, the fused suture, and then the eye will also be elevated. I'll show you an example of that because you can't see this in this view. So everything's pulled towards this fulcrum. Here's the difference here. Here, if you have a plagiocephalic skull, yes, your ear is pushed forward. Yes, it's pushed forward on the side that the back of the head is flat, but here's the difference. The forehead will also be pushed forward because there are no forces holding these bones in any position. They're being pushed from the back, and that vector is allowed to push all the way through the skull, giving you flattening here, the skull base, pushing the ear forward, and then the skull in the front. So your vector is carried all the way through to the front. With coronal synostosis, that's not what's happening, right? You have an internal pulling, you have a stuck fulcrum. So your forehead will be pulled back towards the ear on the side that you're flat. So it's subtle and you get good at it over time. But again, this is why this is all physical exam. Lambdoid synostosis is the most uncommon of them all. You don't need to know it, typically in practice. I'll show you some examples of it. All right, so that's just walking around the wheel of how to diagnose this. So how do we walk through diagnosis? So you use an algorithm because this is your most important tool. And you use the same approach with every child. So physical exam, again, the biggest part of this circle in terms of how to diagnose these children. So how do we approach physical exam? You look at cranial morphology and you start first with looking for symmetry. All right, so you look from the top down at the skull, the view I just gave you. You're looking for areas of asymmetry on the vault. You're looking for areas of asymmetry in the orbits. You're looking for areas of asymmetry in the ears. And if you do that the same way every time and you use that algorithm, you will not miss this. So you're looking from the top down, front on, and from the side, and you're going through the rubric I just showed you. Look at the vault, look at the eyes, look at the ears. And if you go through that every time, you will not miss it. Then you feel the sutures and you feel for ridging. Any suture that is fused is ridged. You have to learn how to distinguish that from overriding, as we just discussed during the birthing process. There's a lot of overriding. Really, the name of the game here is if you have more than one suture ridged and you don't have any compensation, as we just discussed, they're just overriding. That kid just needs some time. They need to gain some weight. Their brain needs to get bigger and they need to push those sutures back into alignment. And then compensation, as we just discussed. Anthropometry. So one other thing we can do is use cephalic index. So we use what's called a caliper. It's a little metal device that measures the biparietal diameter and the fronto-occipital diameter. You divide those two and multiply by 100 and you get a number called the cephalic index. Okay, and that number, if it's in 75 to 85 range-ish, is normal for metastacephaly. If it is less than 75, you're in a dolichocephalic or a scaphocephalic range, meaning you're worried about saddle synostosis. If you're greater than 83 or 85, I don't use 83, I use 85, but then you're in a brachycephalic range, which tips you off that you might be dealing with coronal synostosis. Now, this is just one piece. You would never, ever hang your hat on a diagnosis based on just a cephalic index. It's just another piece. And then if you're still confused, then you can reach for plain films or a CT. But honestly, if you can't tell from physical exam, it's not fused. So I really very rarely use these modalities. All right.
Hey everyone, Ryan Rad here from neurosurgerytraining.org. If you like that video, subscribe and donate to keep our content available for medical students across the world.